I think a lot of the people on our channel are dealing with these sort of complex constellation of symptoms, right? And some seem more acute and greater and life-threatening than others. Let's say I'm someone who has a chronic eating disorder, some kind of obsessive compulsive behavior. I'm in and out of relationships and I barely hold a job, right? But let's say the eating disorder, I associate that with the most profound, that's the thing that has the most profound impact on my life, I've assessed. Would I do better to go directly to an eating disorder person, or would I do better to go to someone trained in a personality disorder framework?
Well, as a person that is more focused on how to approach things in the most broad sense, in a generic sense, the psychiatric management approach really incorporates an understanding of which disorders you prioritize over others. And that strategy was predominantly determined by longitudinal research. And for the most part, borderline personality disorder influences the course of lots of mood disorders, anxiety disorders, eating disorders, depending on which one it is, and substance use disorders. So that information has informed an algorithm of which one you should target first, because for example, if someone's using substances so heavily that they can't retain information and they're chronically generating more problems at a pace that's faster than they can solve them so that they can think first and have a corrective experience, then you have to treat the substance use disorder first. Some substances require that more than others, and the severity of the substance use matters. Eating disorders are much harder to treat than people openly talk about. Patients with eating disorders, because eating is something everybody has to do, they oftentimes have a much more challenging course of treatment. If their eating disorder can be stabilized independently of their personality disorder, then they can do that first and then work on their personality disorder. But oftentimes what I really see is that some people actually can get better from their personality disorder in a lot of ways, but the persistence of their eating disorder sometimes happens because it remains a way that they cope with stress. And sometimes that creates a process where they remain more vulnerable than a person who had an eating disorder and resolved it. And that's a complicated phenomenon, because what helps you stop is probably also the thing that makes your prognosis better for your personality disorder treatment. So I have to say that the overlap of eating disorders and personality disorders isn't clarified enough with the information we have. But I think the clinical reality is that it really depends on the person. Of course, if their eating disorder is so bad they're in medical dire straits, you have to stabilize that first, because no psychological treatment will work if you're so medically compromised by whatever disorder it is that you can't think. And people who are in chronic starvation, who have more restricting eating disorders, their brain changes so that they get more rigid in their thinking, so their changeability or mental flexibility is low, and that will challenge any psychotherapy.
Right. It sounds like, what you are advocating for is a raising of the bar with the way therapists are trained, so that the complex array of problems that might show up in front of them in one person cannot be seen as these distinct entities and sort of not understood in a more holistic sense. And simultaneously, they may have to be treated as sort of distinct entities.
I think of it more like Legos that you can put together to make a coherent object, but you can also take apart to treat each piece of it as separate. And I think modern psychiatry chops people into bits, like you go to this mood disorder, doctor who will give you medication, and then you go to this personality disorder specialist who will put you in intensive therapy, and then you go to the eating disorder place that's going to control your diet and exercise level. That is creating a sense of non-understandability or incoherence for people. And as a field, I think we can do better. I think we're all going to have to work together on it and be patient with the field, because I think that consumers can get very angry at our failures because we're not sophisticated enough. So, I don't say this to be critical of what we've been doing, because we needed to come through this phase in order to move forward into something more sophisticated. But I am saying that we have to embrace the likelihood that everything we do now will be replaced with something that will definitely be better. Those things that we do now might have some benefits that we'll have to sacrifice in order to get to some other improvement, like scalability. If we can just make something more broadly available, it probably won't be as good, but we're going to have to let go of just doing the things that are ideal and be more realistic. Sometimes we have to combine two treatments that might not be as good as the DBTs or the MBTs of the world, so that people can actually get out of the clinic or the hospital or the residential program or the cave of their homes of avoidance, so that they can live life and have corrective experiences that change their mind about themselves and their capacity to be in the world.